Alright, let's jump right into this explainer on renal pathophysiology. Today, we're going to take some pretty dense genitourinary concepts and transform them into high-yield clinical judgment anchors to keep your patients safe. Whether you're gearing up for the NCLEX or just want a rock-solid understanding of the renal system, my goal is to help you cut through the noise. We aren't just memorizing definitions here. We're building real pattern recognition.
We're going to start right in the middle of a high-stakes clinical trap. Picture this. Do you know the immediate priority action when a patient on continuous bladder irrigation experiences sudden, intense pain? Imagine you're the nurse. The primary care provider is waiting for your assessment. Your patient hasn't voided properly. Their lower abdomen is visibly distended, and they are in absolute agony. Pause and think for a second. What would the nurse do first? We're going to solve this exact scenario together.
Why does this matter so much? Because the exam, and frankly, real-world nursing, isn't just about reciting textbook facts. It's about putting you on the front lines to identify life-threatening complications before they spiral out of control. Safety is the ultimate priority. Your ability to apply clinical judgment, spotting those subtle cues, analyzing them, and prioritizing your hypothesis is literally what stands between your patient and a severe complication.
So here's our game plan today. 1. Core concepts simplified. 2. Priority alerts for infections. 3. Obstruction traps and mnemonics. 4. A mini NCLEX clinical scenario. And 5. A rapid-fire recap.
Section 1. Core concepts simplified, the renal engine.
Think of the glomerulus within Bowman's capsule as your body's ultimate filtration barrier for removing waste and making urine. Blood rushes in through the afferent arteriole, hydrostatic pressure forces the plasma and solutes right through that barrier, and the filtered blood exits via the efferent arteriole, while the leftover waste travels down the tubules. This tiny, microscopic structure is incredible. It regulates everything from your fluid and electrolyte balance to your acid-base blood pH, keeping it tightly between 7.35 and 7.45. It even manages blood pressure using renin and promotes bone integrity by converting vitamin D. It does a lot.
You absolutely have to have this definition for GFR locked in. Knowing that the normal rate is 90 to 120 is essential for figuring out how much a patient's kidney function can fluctuate while still keeping them hemodynamically stable. Here's the bottom line. GFR is your ultimate scorecard for kidney health. While BUN and serum creatinine are definitely vital labs, GFR tells you exactly how well that glomerular barrier is actually working. If you see a drop in this number, that is a massive clinical cue that your patient is heading into dangerous territory.
Section 2. Priority alerts for infections, ascending dangers.
You've got to spot the difference between a straightforward lower urinary tract infection and a severe upper infection, like pyelonephritis. A lower UTI, or acute cystitis, usually just has localized symptoms. But the second that infection travels up the ureters and into the kidneys, you're dealing with an upper UTI, and that is an absolute NCLEX safety alert. Your priority shifts completely, because an upper UTI can rapidly progress into full-blown sepsis.
Just look at the physical damage this causes to the kidney tissue. An acute pyelonephritis infection creates these localized purulent pockets. If you don't catch it and treat it aggressively, it goes chronic. The kidney ends up shrunken, scarred, and totally irregular. This should instantly remind you that when a UTI patient suddenly has flank pain, a high fever, and systemic symptoms, you jump on it. You aren't just treating a symptom anymore. You're actively saving that kidney from permanent, irreversible destruction.
Section 3. Obstruction traps and mnemonics. Flow and retention.
All right, here is a classic test trap. Mixing up your incontinence interventions. Let's chunk these together with a quick memory trick. Match stress incontinence with strain, like a cough or a sneeze. So the fix is physical, pelvic floor muscle training. Match urge incontinence with an overactive, spasming bladder, which means we need pharmacology, like urinary antispasmodics and bladder relaxants. If you lock those pairs into your head using that pattern, you will never fall for the trap of giving a bladder relaxant for a simple cough.
If you have a patient with benign prostatic hyperplasia, where someone post-TURP, mastering the continuous bladder irrigation or CBI setup is an absolute non-negotiable. A TURP procedure leaves raw tissue that bleeds heavily. To stop clots from forming and completely blocking the urethra, we use a three-way catheter system. The irrigation bag constantly flows fluid in, washes the bladder, and immediately drains right back out into the collection bag.
Your whole job here is actively managing those tubing ports and the drainage bag to prevent clots. Which brings us right back to our opening clinical hook. You need to constantly check the color of the drainage. We want it light pink, absolutely not dark red or ketchup colored, and you have to meticulously measure the output. That means subtracting the fluid you pumped in from the total volume in the drainage bag. If that outflow suddenly stops or the patient screams in pain, boom, you've got a major obstruction on your hands.
Section 4. Mini NCLEX clinical scenario, putting it to the test.
Bringing it back to our post-op TURP patient feeling fullness and severe pain. Let's run straight through the clinical judgment framework. Step 1, recognize the cues. Sudden severe pain, no voiding. Step 2, analyze. Why the pain? Well, the bladder is filling up with continuous irrigation fluid, but nothing is draining out. Step 3, prioritize. This is an acute urinary retention crisis, most likely a blood clot blocking the catheter. Steps 4 and 5, solutions and action. You do not wait around for a doctor's order here. You immediately assess the tubing for kinks, and if it's clear, your first nursing priority is to manually irrigate that catheter to clear the clot and restore the flow. Finally, step 6, evaluate. Did the pain resolve? Did the drainage return? That is exactly how you need to think for the exam.
Section 5. Rapid Fire NCLEX Recap. Locking in the knowledge.
Let's lock this in. Commit these concepts to memory. GFR is your ultimate scorecard, baseline 90 to 120. Remember that flank pain and a high fever mean the infection has climbed to the kidneys, making it a massive, life-threatening priority. Always chunk your incontinence therapies logically so you don't mix them up. And never forget, if your CBI patient has sudden, severe pain, check the tubing patency first.
I'll leave you with one final provocative thought to test your clinical judgment. When that filtration system completely fails, what silent electrolyte imbalance is waiting to strike? Think back to the renal engine's job. If the kidneys can't filter, potassium builds up and hyperkalemia can trigger fatal cardiac arrhythmias. It's all connected. Keep looking for those cues, keep analyzing, and I'll see you in the next explainer.